if I
You
can.
can actually record it through PowerPoint as well.
Oh, not with Max, but
Okay.
Okay, so patient presents bee sting. He's been stung before, but only mild response. Now he has tachycardia, tachypnea, pale, drowsy, angioedema, inspiratory and expiratory stridor. What's your provisional differential diagnosis? How would you manage this patient? What investigations would you perform? And interpret this ABG and ECG. So this would be the 4 questions you would have on the piece of paper that's given out to you. So you would have all of this information at the beginning. And then the additional questions are hidden from you, and that's if you have time, and the examiner is going to ask you these for probably the P plus answers. So in terms of how I would approach this question, this is like what you expect to be like by the time you get to biomed. This is at the beginning of year, so don't stress too much. So just look at the structure and just like use this for trying to do the other questions. So I would respond to this being like my provisional diagnosis anaphylactic shock and with the history of urticaria angioedema. However, my differentials include anaphylactoid reactions. However, this usually is a longer onset. It doesn't occur within seconds like anaphylaxis. Other differentials for shock can be divided into hypovolemic, septic, cardiogenic, obstructive, and neurogenic. You also want to exclude a foreign body obstruction, which is a very good differential for anaphylaxis. Lower respiratory tract, such as severe asthma attack and status asthmaticus, cardiac acute myocardial infarction, but unlikely in this person, and psychogenic, a panic attack. How would you manage this patient? So I would start by saying that this is an medical emergency, and I would transfer this patient into a resus bay and call for assistance from senior medical staff. I would first then lay the patient flat, remove the allergen, and then second, I would immediately give intramuscular adrenaline 1 to 1,000, 0.5 milliliters, mid-lateral outer thigh. And this is something like one of the doses you must remember for biomed and for the rest of your lives. Like a lot of the antibiotics you don't need to know, but adrenaline you do. I would go into that later. And thirdly, I would start resuscitation, looking at my A, B, C's, and D's. Specifically focusing on a B, so giving them high flow oxygen using a non-rebreather mask, 6 to 8 liters, to try and get the saturations up, because basically they're from the ABG, they're obviously hypoxemic. And you want to exclude alternative diagnosis for anaphylaxis at the same time. So in terms of intramuscular adrenaline, you give it once and then you observe. And sometimes they just respond within minutes. But if they don't respond within 5 minutes, give it again, give it again, give it again. And I think you can give it as many times as you want if they're not responding, but usually they respond within the first 1 or 2 doses. If they don't after the 4th one, you can start about thinking an IV adrenaline infusion, but you need an ED or an ICU or a critical care specialist to do this because the doses have to be exact. So you need to mix 1 ml of 1 to 1,000 adrenaline and 1,000 ml of a normal saline. And essentially you can just try and remember this. So you want to start the infusion at 5 ml per kilogram per hour. And titrate up and down according to the response, looking at their heart rate and how they're responding. And you need to monitor them continuously. So you need to put on ECG pads, and you want to try and monitor their blood pressures. So the more accurate way to monitor blood pressure is putting a radial line in rather than using the cuff, because the radial line is like a real-time blood pressure. And do not give IV boluses of adrenaline due to the risk of cardiac arrhythmias. If you have a cardiac arrhythmia, then you give IV adrenaline boluses. So the doses, so someone like their heart doesn't work, that's the only situation from your ALS and BLS which you would give IV adrenaline. And it's at much higher doses than anaphylaxis. So what investigations would you perform? I like to divide my investigations for any kind of case into bedside, bloods, and imaging. So I would go bedside, you want to do an ABG for acidosis and hypoxemia. For bloods, I would do a serum tryptase. This is released from the secretory vessels of the mast cells, and they're taken immediately 1 hour when it peaks in anaphylaxis and 6 to 24 hours afterwards. And you have a true anaphylactic event if it's greater than 15 nanograms per ml. You don't have to remember this, but just remember tryptase as the marker for anaphylaxis. People also talk about histamine. It's rarely performed because it peaks at 10 minutes and everyone's scrambling and no one can get it in time. And it goes back to baseline at 1 hour. But that's just like a side trivia. You can also do a total IgE as an indirect marker of allergic inflammation and an eosinophil count again. You want to do a full blood count looking for eosinophilia in the white blood cell differentials and blood cultures for infective causes, EUC's liver function tests for electrolyte imbalances secondary to shock, which may lead to multi-organ failure. So they will have elevated transaminases and or like renal failure, ECG, and ECG should be up in bedside, and troponin just to exclude a cardiac cause. And imaging, chest x-ray to look for acute respiratory distress syndrome, which occurs after anaphylaxis sometimes where you have a ground glass appearance.
Ruth, question.
Yes.
So the tryptase peaks at 1 hour.
Yes.
6 to 24 hours, I'm assuming it reduces, but the
Yes.
true anaphylaxis level, would that still remain above 15 between 6 and 24 hours?
I'm not sure, but usually when they have anaphylaxis, it gets pretty high. But if they've had a mild one or it was that first one, it'll like come down a bit faster. So yeah, in any of those like tests, if one is above 15, that's a diagnosis of anaphylaxis. But the diagnosis of anaphylaxis is actually clinical. So you don't need this tryptase to diagnose anaphylaxis. So probably just read up on the different criteria that they use to diagnose anaphylaxis. There's so many different ones, but the general trend is that they need to have involvement of either the respiratory and cardiac and or gastrointestinal and another system involved. And it varies depending on which guideline you read, but just choose the easiest to remember. So this is talking about mast cell and why is it so useful to look at tryptase. It's because it's released from the mast cells after degranulation, and 99% of the body's tryptase are in mast cells and they only get released really in anaphylaxis. And so the half-life is 3 hours versus 3 minutes for histamine. So interpreting this ABG and EUC, you did a really good job. You found the two abnormalities. There were no other ones. So arterial blood gas, this patient is acidotic, hypoxemic, and hypercapnic. So this would put the patient into type 2 respiratory distress. And clinical chemistry, the bicarbonate is low. So this is metabolic compensation for the respiratory acidosis. And the respiratory acidosis, the pathophysiology behind this is that they get angioedema of their lungs, which causes airway obstruction and prevents ventilation. So they get hypoxemia because the oxygen can't go in, and hypercapnia because the carbon dioxide can't go out. And then they get metabolic acidosis because if you don't have oxygen within your blood, it causes anaerobic respiration. They get lactic acid production, which consumes the bicarbonate and causes the metabolic acidosis. So I take back what I just said back then. So this patient has mixed acidosis, so both metabolic as well as respiratory acidosis. Explain the pathophysiology behind clinical manifestations. So in terms of the stridor is an upper airway disease, not a lower airway. Lower airway is wheeze. So the upper airway is caused by the laryngeal edema from the histamine and nitric oxide. The wheeze is from the histamine that increases leukotrienes that causes the bronchoconstriction, so that's lower airway. Tachypnea, it's because the body is trying to compensate for the hypercapnia and the metabolic acidosis with the chemoreceptors in the peripheral chemoreceptors and medulla. The hypotension and tachycardia is due to the vasodilation via histamine and nitric oxide and compensatory increase in heart rate to maintain a blood pressure. They become drowsy and incoherent because of the cerebral hypoxemia and hypoperfusion, and they get an itch because the histamine directly irritates the nerves. And they get swollen tongue, face, eyes, urticaria because the histamine acts on histamine 1 receptors, which increase permeability, and then they get extravasation of fluid into their body. Explain why the patient has reacted with anaphylaxis only now and not previously. And you answered this question really well. in that the patient first needs to be sensitized before developing anaphylaxis. So sensitization phase, what happens in terms of pathophysiology is that the antigen is detected by an antigen-presenting cell, which presents it on its MHC class 2 to naive T cells. The T cells then secrete interleukin-4, and then they differentiate to become T helper type 2 cells, which then produce interleukin-4, 5, and 13. These then activate B cells to mature into IgE-producing plasma cells. The FC portion of the IgE, so that's the bottom portion of the 2Y at the top, it binds to the surface of the mast cells. And so these mast cells are basically covered with IgEs with all of their arms out like a Y. And then the next stage is the mast cell activation stage. So it can be divided into the acute phase within minutes and a late phase. So the acute phase is what this patient is going through. So once they get re-exposed to the antigen, this is the key word, cross-links multiple IgE antibodies on the mast cell. So it's like this giant antigen, it comes along, and then all these like IgEs are on the mast cell, and if you cross-link two, that's when it gets activated. If you just activate one of the IgEs on the mast cell, nothing happens. So it will bind because the IgEs are quite small compared to the antigen. This increases cyclic GMP and causes the degranulation of histamine, adenosine, serotonin, prostaglandin, ECFA, which stands for eosinophil chemotactic factor, of anaphylaxis. And then the late phase is this thing called slow reacting substance of anaphylaxis, which increases the production of prostaglandins and leukotrienes and all these other ones. And this happens 6 to 24 hours later.
Do you have time to say all of this?
No, so the reason why this won't be, the thing with anaphylaxis in biomed, it's in a lot of the different, so you have it in pharmacology, you have it in pathophysiology. So only one of these will be used depending on what question and what case it comes up. But if you're in the pathophysiology stage, you might want to talk about this. If you're in the pharmacology stage, we'll go through like how you would explain adrenaline.
I was just thinking like if they gave you a scenario and they were like, okay, what are the 5 main interleukins that are used in anaphylaxis, and then like to remember all of that.
Yeah, no. If any, like just naming one is enough. So this is going into a lot of detail because it'll also come up in 6th year. So it's good to get like to understand anaphylaxis really well because it's very important as well in the future. Can you give adrenaline IV? Your answer was correct when you said no. So no, you don't want to give IV boluses of adrenaline because it causes cardiac arrhythmias. However, if they have cardiac arrest, you just want that heart beating. That's when you give your IV boluses. So just remember the key differences because that's how people die in ED. Like people get confused, like if it's IM or IV. So it should be intramuscular for anaphylaxis. Just remember, anaphylaxis is not as serious as the heart stopping. So you want to give the lower dose in a less fast way. Explain the mechanism of action for adrenaline. So this is a question that would come up if you had it in your pharmacology station. And you would be like, adrenaline is a non-selective adrenergic agonist. So it acts on beta 1, beta 2, and alpha 1. So beta 1 increases your heart contractility, rate, and conduction, and the renin activation system. So just think about B1 for the heart. B2 is just dilating everything. So it's just like relaxing. So you get vasodilation of smooth muscles. You get bronchodilation. You stabilize the mast cells. This is just an extra one that you should also remember is B2, the mast cell stabilization. And alpha 1 is constriction, vasoconstriction of the spleen and splanchnic to reduce the mucosal edema. Just remember, alpha 2 is not here. Alpha 2 is a receptor on presynaptic neurons. That's different. They do alpha 2, if you activate it, it actually does the controversy whereby it shuts down your sympathetic nervous system. So what follow-up treatment or advice would you give to a patient post-anaphylaxis? Your answer was really good. You covered the main points. So you want to make sure that they have an EpiPen. You want to organize that they have one and tell them to carry it all the time. I think PBS only covers it for 2, so you keep one at home or on yourself and one at school. And if you want more, I think you have to pay out of your pocket. And you want to train the patient in knowing how to use it, and give them an ASCA action plan. So this is an Australasian Society of Clinical Immunology and Allergy plan. It's like an asthma plan, but for anaphylaxis. You want to refer them to an allergy specialist because they need to find out exactly what they're allergic to. And if a patient is like allergic to penicillin, you're worried that they're probably also allergic to a lot of other drugs. So you want to exclude that by asking them to go to an allergy specialist, and they'll do the tests, and will also provide whatever, like an anaphylaxis asthma plan. And they can also have immunotherapy for those who are allergic to insect venoms. And you want to document the anaphylaxis and teach them how to avoid the cause and trigger. And like if they have latex, tell them that balloons have latex, gloves have latex. So how do you find the definitive cause of anaphylaxis? You want to do skin or intradermal testing. This is the gold standard test. You also have ImmunoCap Test, which is a fluoroimmunoassay, and RASS test, which stands for radioallergosorbent test, for IgE antibodies. This one is superseded by ImmunoCap Test, which is relatively new. But this one is still gold standard. But the problem why people don't want to use the first one, even though it's gold standard, is that there is a risk of anaphylaxis when you do this test, whereas these are like blood tests. So they're not going to get an anaphylactoid. But this is the reason why the skin one is gold standard. You'll see next is that it's useful for the diagnosis of anaphylaxis, not anaphylactoid. Beware, there is difference between anaphylactic and anaphylactoid. I think I go into that later. Anaphylactoid is a little bit later, and it's not really to do with IgE cross-linking activation. You want to do it 4 to 6 weeks after they have their anaphylaxis, because they need the IgEs to be regenerated. When they've had the anaphylactic attack, the IgEs are totally gone. They can't have...
If you have 2 episodes of anaphylaxis within 2 weeks,
yeah,
let's say, would you still have a proper like anaphylactic reaction the second time around upon exposure? If you don't
it would be less serious because you've kind of run out of your your IgEs and histamines. So you don't want to give them, they can't be on antihistamines 5 days before, otherwise the test is going to be false negative. You want to use saline as a negative control and histamine as a positive control, and a positive result is if the wheal is 2 millimeters wider than the saline prick. Because like some people have like dermatographia, whereby like you just prick them and then they have like this ginormous mound. So they would be positive for everything just because of the prick. So that's why you need saline as a negative control. And if it's positive, this is important, you want to repeat it with a 1 to 10 dilution to reduce a false positive. And then you want to test all the other drugs in the same class to make sure that they're not allergic to that as well. ImmunoCap Test through immunoassay, you can read this in your spare time. RASS test, I don't know much about it because it's been superseded, but I believe it's very similar to the ImmunoCap Test, but using a different method. And do you guys want to go into more depth, or do you think that's enough? Anaphylaxis. Just like, it's good to just like hear this once, because you will eventually learn all of this in the end. So just hear it, like you don't necessarily have to know this for biomed. So if a patient has persistent bronchospasm and wheeze, is this upper or lower respiratory? This is lower respiratory. Anything wheeze related is lower respiratory, and the treatment is very similar to asthma. So bronchodilators and corticosteroids. So this is after you give them the adrenaline. You can give this on top of them. Salbutamol, 8 to 12 puffs using a spacer, or you can give 5 milligrams nebulizer, corticosteroid, oral prednisolone, 1 milligram per kilogram, maximum 50 kilograms. So if they're 70 kilograms, don't give them 70 milligrams, just 50 milligrams, or IV hydrocortisone. If they have persistent hypotension, basically do whatever you can to increase blood pressure. So usually the first line is you give an IV bolus dose of 20 milligrams per kilogram. But then if their blood pressure doesn't rise, you can try giving them another bolus, but don't go past 50 milligrams per kilogram in the first 30 minutes. Otherwise they're going to go into acute pulmonary edema. If they have cardiogenic shock, you'll have IV glucagon bolus dose, 1 to 2 milligrams. And a lot of people don't know the reason why this works, but basically, like, the receptor for adrenaline acts through like a adenylcyclinase. The glucagon binds to like its own receptor, but acts in the same pathway. So some patients who are on beta blockers, the beta blockers are bound to the beta receptors. So your adrenaline isn't going to work at all because you've got beta blockers on board. So you give them IV glucagon because it basically does the same thing. It's got its own like receptor that does a similar result to adrenaline. Some people believe it like displaces or like kicks out the beta blockers. That's no, it binds to another receptor. And if they're still hypotensive, yeah, you can give IV bolus or an infusion like adrenaline. And there are selective vasoconstrictors such as metaraminol and vasopressin. You don't have to remember the doses, just remember the names like metaraminol, vasopressin, and then you can remember like what its action is if you have the time. And invasive blood pressure monitoring. So when they mean by invasive, that is a radial line. Persistent angioedema and upper airway obstruction. The aim is to reduce inflammation. So this is upper airway, so they'll get a stridor instead of a wheeze. And you can give nebulized adrenaline because the key thing here is to reduce the edema up there. You can also do airway management that you learn in BLS, jaw thrust, NGA, bag valve mask, and then like end stage, tracheostomy, ETT. So some patients can actually go into cardiac arrest or they have just so much vasodilation and fluid extravasation that they're just like so swollen that if you give them adrenaline, it's probably not even going to get into their bloodstream because they have such a poor circulation. So they need IV adrenaline bolus, like a cardiac arrest protocol, and that's 1 milligram every 2 to 3 minutes. And this is a high dose. Like this is cardiac arrest dose, as well as IV fluid resuscitation. And all people should be observed for 46 hours after the last dose of adrenaline. Because of the biphasic reactions, like you mentioned, it occurs in 3 to 20%, so a large majority. And they usually occur in those who had a really severe anaphylaxis. And it's fine because like the criteria to admit into hospital is like severe anaphylaxis just to monitor for biphasic, uncontrolled asthma, slow response to adrenaline, needed a second dose of adrenaline, a fluid bolus dose, inadequate response to treatment, or the person lives a far distance from medical services.
What's biphasic, sorry?
Pardon?
What's biphasic?
Biphasic, basically, so you remember how I mentioned you have histamine as your acute phasant reactant, and the biphasic occurs because of the SRS, the slow reacting substance of anaphylaxis, and so that's released when you have an anaphylactic reaction, but it doesn't do anything. It causes like prostaglandins and the other things to be made, and leukotrienes, and by the time they're made, that's like 46 hours, they get it again. So that usually happens when they have a really severe anaphylactic reaction. So they need to be observed for their biphasic reaction. So yeah, that was my presentation on adrenaline.